Hi everyone, this is Michelle Van Raven Cajitas, and this video contains a review of the article entitled Adrenal Insufficiency in Coronavirus Disease 2019, a case report. The article discussed the condition of a COVID-19 patient who was later on diagnosed to have adrenal insufficiency. As a short background, coronavirus was detected last December 2019 at Wuhan, China. This pathogen has infected a large number of populations in the entire world. Approximately 2.8 million cases of COVID-19 have been reported as of April 2020. This pathogen greatly affects the respiratory system of the human host. Moreover, according to studies, patients who contracted this virus may develop sepsis, which can happen very quickly and lead to tissue damage, organ failure, and death. Adrenal insufficiency, also called Addison's disease, is a condition in which steroid hormones were not released adequately by the adrenal glands. Symptoms develop slowly. Thus, it takes time for this disease to be diagnosed. To continue, as mentioned earlier, this paper presented the case of a COVID-19 patient having adrenal insufficiency. But complications do not end there. The patient also had a history of hypertension. Death may occur in a short time due to these complications. We may then ask how the man was saved. How did he escape death? Very interesting, right? Furthermore, this article is really timely and helpful to healthcare workers. This article put emphasis on the importance of early diagnosis of diseases, especially to those COVID-19 patients. Also, the article is informing healthcare professionals that COVID-19 does not only manifest through the host respiratory system but also in some other organ systems. Lastly, this article can save lives, especially to those having the same condition as the patient in the article. The case was presented through the qualitative observation of the condition of the patient. It goes like this. A 69-year-old Iranian man was brought to the hospital on the 27th of February 2020. He was complaining of fever, dyspnea, and dry cough. He had a history of hypertension, thus he was administered with antihypertensive agents to control his hypertension. After his initial vital signs were taken, the doctors diagnosed the man to have respiratory problems. Thus, he underwent chest CT scan. The chest CT scan showed bilateral and peripheral ground glass pulmonary opacities, suspicious for COVID-19 infection. His reverse transcriptase polymerase chain reaction test, or the RT-PCR test, resulted positive of COVID-19. Since the diagnosis had been finalized, he was then admitted to an isolation room. The next day, he was transferred to the ICU because his condition got worse. His dyspnea worsened, and even being administered with 75 milligrams of siltamivir and 200 milligrams of chloroquine every 12 hours, that is based to the national protocol, his fever continued to peak at 39 degrees Celsius. Blood culture, tracheal aspirate, and urine cultures were taken. Empirical antibiotics were prescribed. On the 5th day of his admission, his condition got complicated with an acute hypotensive episode and diarrhea, which initially responded to fluid resuscitation, but recurred 1 hour later. The doctors then suspected the patient to have adrenal insufficiency because the result of his electrodiogram showed tachycardia with no STT segment changes. Therefore, as his case was suspected with adrenal insufficiency, hydrocortisone was administered at a dose of 100 mg, followed by 10 mg per hour, administered intravenously after taking a blood sample for a random plasma cortisol level measurement. This method has been suggested to be as effective as a 4-dose divided intravenous hydrocortisone prescription. The serum total cortisol level was 12 micrograms of lead per deciliter of blood. Therefore, no concentropine stimulation test was ordered. Intravenously administered hydrocortisone had been administered up to 3 days after the stabilization of the patient's clinical status in the absence of a vasopressor prescription. His blood pressure remained stable at 110/75 mm of mercury, and he did not receive any antihypertensive agents because of a prior history of hypertension. He had several further episodes of hypotension in the absence of any vasopressor agent administration during his ICU admission, when his corticosteroid regimen was reduced or withheld to perform repeated serum cortisol levels measurement.
During his hospitalization, he had 3 episodes of fever due to nosocomial infections. He was prescribed with antibiotics based on the results of blood, tracheal aspirate, and urine cultures. On the 53rd day, his general condition was good, and he received supplementary oxygen via a venturi mask at 40%, as well as a daily orally administered prednisolone with a dosage of 10 milligrams.
As mentioned earlier, this article presented a case of an individual infected with COVID-19. Accordingly, the patient has no history of adrenal insufficiency, but after being admitted and diagnosed to be infected by COVID-19, the patient experienced acute adrenal insufficiency. Healthcare professionals must take into account that coronavirus may not only affect the respiratory system, but also some other organ systems, especially the endocrine system. In that manner, COVID-19 is suspected to be responsible for the occurrence of adrenal insufficiency of the individual mentioned in this article. The following are the assumptions and reasons as to why coronavirus was suspected to be responsible in the occurrence of adrenal insufficiency in the patient of this article. First, the cytokine storm that resulted from systemic infection caused by COVID-19 might be responsible for the development of adrenal insufficiency. Second, it has been suggested that an older member of the Coronaviridae family, named Severe Acute Respiratory Syndrome or SARS, produces certain amino acid sequences mimicking host adenocorticotropic hormone or the ACTH. Consequently, antibody production against this peptide might be responsible for the occurrence of adrenal insufficiency. Moreover, the hypothalamus and pituitary express angiotensin converting enzyme 2, or the ACE2, and SARS genome had been identified in autopsy samples. Therefore, this new coronavirus might also affect the HPA axis and cause acute adrenal insufficiency. As a conclusion, based from the case presentation, the case report shows that early detection of adrenal insufficiency is life-saving among critically ill patients infected with coronavirus, especially to those unresponsive to vasopressor agents. However, the author suggested that the exact manner of causation of adrenal insufficiency needs to be investigated further. Lastly, the methodology of the study is mixed, a combination of a qualitative method and secondary data analysis method. Qualitative method because the data gathered were based on the patient's condition, and secondary data analysis method because some of the information, especially in the discussion part, were taken from other previous studies.